Hi, Dr. Fazal. I think you can check the slides. Actually, you can try sharing it.
Okay, okay. You are able to see, Jay?
Yeah. And at full screen, you can try now.
Yeah.
Okay.
Okay. Shall we start or we'll wait for a couple of minutes more?
You can start now.
Okay, okay, we'll start then. Just a second. Good evening, everybody. Welcome to another case discussion. This is part of the continuous medical education especially for the fellows. So I've just got a couple of cases more. This is part of an extension of the presentation that I had done last week. As usual, our host is Dr. Jayashankar. He just finished his fellowship from Rajagiri Hospital. And we are also joined by Dr. Kaushik Sundar, who's an interventional neurologist practicing currently in Narayana Hridayalaya in Kolkata. He finished his MD and DM from Ramchandra Medical College and Research Center in Chennai. And after that, he did his fellowship in stroke and interventional neurology from Rajagiri Hospital in Cochin. And currently, he's the clinical lead for the Comprehensive Stroke Center for the Eastern Cluster of Hospitals in Kolkata. And he has his own fellowship program where he is training fellows currently. So thank you for accepting our request, sir, and welcome to this discussion.
Pleasure, Dr. Fazal. Let us see whether I can help you guys. Let's see how we can do.
I'm just presenting a couple of cases, sir. Which we had done in our center. So just I'm going to present as a step-by-step where I'm going to present the history and how we did it, and if at all somebody can volunteer, if some of the fellows can volunteer, what would they do in this kind of a scenario. And if at all, we would just like your inputs also, if at all it could have been done differently, because currently so many techniques are coming up in thrombectomy and each perspective is different. So I'll just start with the cases. I've brought a couple of cases today. So let us start with the first case. Sorry. So here is a 60-year-old gentleman who was referred from another center with complaints of right-sided weakness and aphasia. His time of arrival to the hospital was at 2 p.m. on 6th of this month. His last known normal was at 1 a.m. on the same day. And NIHSS at presentation was 22. He was taken to another hospital at around 8 o'clock or 8:30. Because it was a wake-up stroke, he was not thrombolized. Instead, he was given a loading dose of clopidogrel and aspirin and 40 mg of atorvastatin. and later referred to our center for further intervention. So this was the MRI done there in the outside hospital. As you can see, there is a diffusion restriction, one in the gangliocapsular region, capsulionic region, and also in the insula and in the external capsule, and also in the operculum, and also in the corona radiata and the precentral and inferior frontal gyrus. And this was the image, diffusion restriction and the ADC, and the aspects was around 4. And sorry, I apologize, there was no flare image with the image that they had got, so I am not able to bring the flare for your reference. And this was the MR angiogram. As you can see, the left ICA is not visualized. You can see the ICA on the right side, and you can see the left side ACA filling from the opposite side. So this was the MR angiogram. So as you can see, the last known well was 11 o'clock. 1 o'clock, and presentation is at 2 o'clock. Almost the presentation now is last known well. You can take it as 13 hours from the 13 hours from the last known normal. So my first question would be whether to take this patient for thrombectomy or not. Because I don't have the CT perfusion and neither do I have a flare, just let us assume that there are no flare changes or minimal flare changes, and this patient has got a flare change. So if any fellows can volunteer and to answer this question, whether this patient needs to be taken for a thrombectomy or we should go for a conservative management. Anybody who can volunteer, they can switch off their mics and please get into the conversation. Anybody?
It is a complete ICA occlusion thing, and NHS is 22.
Okay.
Means,
okay.
Based on that, there should be some mismatch, clinical and radiological mismatch should be there. So there should be some penumbra still. We can go for thrombectomy here if the flare changes is not very obvious or.
Okay. Okay. Kaushik sir, this is Dr. Justin. Actually, he is doing his FNB in Udaipur. So, just sir, how to proceed with this case, sir? His answer was that if at all obvious flare changes are not there, to go forward with the thrombectomy. My question is, even if at all the patient had some obvious flare changes or with minimal flare changes, how to approach this case, sir?
Okay, Fazal, you have put me in a tight situation. Can you go back to the MRI?
Yes, sir. Yes, sir. Sorry.
Can you go back to that MRI?
Yes, sir. Yes, sir. I understood. Jay, I'm not able to move the slides. How to do it? Sorry, sir. Just a second.
Yeah, take your time.
Jay?
Hello. Try end the slideshow and try from the MRI slide. Press escape.
You can see now?
Yeah, I can.
Yeah, then
yes, sir.
click the,
yes, sir.
Yeah, from here you can start.
Yes, sir.
Yeah. Okay. Do you want to magnify this, or can I just go with this?
Sir, you want me to? I'll just magnify. So the problem is that once I magnify, I'm not able to move the slides, sir. So if you don't
check again, if you can.
Yes, sir. One second.
Meaning just put back on the slideshow.
Yes, sir.
No.
Yeah. No. You can. Yes, sir.
Oh, fantastic. Okay. See, let us start with the simple things as to guidelines, and then move on to understand how we could be different in this case from guidelines. Okay.
Okay.
When you see a guidelines point of view, the first thing that guidelines say is that if you have a stroke where there is a uncertain, last seen normal is at say 1 a.m. and he has come to us much later. And obviously this patient, you have an MRI that is already showing a diffusion and an ADC, and your you don't have a flare, but ideally in these conditions, either you should have a clinical radiological mismatch, or you should have a perfusion diffusion mismatch. Basically, you should either have a small core and a large area of salvageable ischemic tissue. That is how the theory goes, correct? Am I audible, right?
Yes, sir. Yes, sir.
Now,
You're
so
audible.
when we look at it from that point of view, we don't have enough details to say whether this patient would benefit, because we do not know what the MRI is going to show or what the CT in toto is, and you have probably put an aspects of 4, correct? Am I
Yes,
right?
sir. Yes, sir.
That is an MRI aspects you have put.
Yes, yes, sir.
Okay. So MRI aspects, again, we'll take it aside. If this was a CT aspects, and or we use a CT perfusion, or we use the Dawn or diffuse criteria, we are probably not having enough information to say whether this patient would be beneficial for thrombectomy or not. Okay.
Okay.
So if you are a hardliner, if you are a person who is probably looking into thrombectomy and looking at a left MCA, the cost involved and the guidelines, then this will not be an ideal case for you. So I'll start with a no. Okay.
Okay. Yes, sir.
But as you have rightly said, Dr. Fazal, intervention as a field is evolving, correct?
Yes, sir.
Now,
Yes.
what I would like to bring to your notice is, look at your diffusion and ADC images here, especially your diffusion restriction. I'm sure this is your diffusion restriction, right?
Yes,
So
sir.
definitely you are seeing an evidence of a left MCA territory infarct that is coming up. Very clear, correct?
Yes,
You
yes.
don't have the T2 flare images, that is fine. But what is very striking is, can you see that your cortical areas have a more diffusion restriction than your subcortical areas? Are you able to make out that?
Yes, sir. Yes, sir.
So you have your, let us say, your thalamic perforators, or possibly your gangliocapsular areas, or the caudate, however you put it. Those areas have a relatively reduced diffusion restriction compared to that of your diffusion restriction that is there more in the cortical areas, correct?
Yes,
So
sir.
why this is important is, this is a very interesting analogy which I keep telling my fellows, that
Yes.
imagine the brain, the gray matter and the white matter, or the cortical and subcortical areas, to have something like cell phones and cell phone towers.
Okay.
Your gray area are like cell phones, and
Okay.
your white area that is subcortical is like cell phone towers. Now,
Okay.
supposing if you lose a cell phone, what will you do? You will probably borrow somebody else's cell phone and start making the call, correct? That
Yes.
is in medical terms, it is neuroplasticity. Okay.
Okay.
So
Okay.
if you lose the sylvian area, you would have seen so many people with aphasia. Over time, their speech improves because their gray matter shifts from one place to another.
Yes, sir.
But the subcortical area is like your cell phone towers. Now, no matter how many cell phones you have, as long as your cell phone towers are not intact, then you cannot make that call anyways. Which
Yes, sir.
means your white matter, which is subcortical area, is the area that you need to preserve. That
Yes.
is why when you have, I'm sure you would have seen this, right MCA territory infarct, left MCA territory infarcts, M1 occlusions. But even in those M1 occlusions, the more proximal the occlusions are, the more deadlier the infarcts.
Yes,
The
sir.
more distal the occlusions, it is relatively easier to have a patient like that. So when
Yes.
you show me this MRI, I'm just talking about this case and this case in particular.
Yes,
So
sir.
if I had to be a devil's advocate and argue this case,
Yes,
my
sir.
argument would be, yes, this is a patient who has come outside your window period. Your NIHS is pretty high, and you don't have any other image to tell you.
Yes,
But when
sir.
I see this feature that the subcortical areas are relatively spared as compared to the cortical areas, and there is definitely some signal intensity changes that still not appeared in the subcortical areas, this would still give me enough incentive to go in and open the vessel. Correct?
Okay.
Now
Yes.
we have a lot of studies which are talking about beyond Dawn and beyond diffuse. I'm not going into those details, obviously,
Yes.
because they are just studies. They have not come into guidelines.
Yes.
But if you ask me what is the incentive to go for this patient, then the incentive for me would be that this is a patient who has probably had, from this image itself, there's a proximal M1 that is occluded, correct?
Yes, sir. Correct. Correct.
Correct. Now, why the ACA is not involved, correct?
Yes, sir. Yes, sir.
And when you show the angio, already you know that the bilateral ACA is coming from the right side.
Correct. Yes, sir.
So for all practical purposes, this is like a left proximal M1.
Yes, sir.
So if I'm able to salvage the subcortical areas and the cortical areas are gone, still I would feel that the neuroplasticity will take over in this case and possibly will be able to salvage a good amount of brain.
Okay.
So if I have to argue for mechanical thrombectomy in this patient, being a devil's advocate, I will say because the subcortical areas are not as involved as the cortical areas in my diffusion restriction, this would be my incentive for me to go in.
Okay, sir.
Then the next important question that we ask is, the Calgary, I think, is already started doing it, is no longer are infarcts being considered as best imaged by diffusion restriction or ADC. Because there are a lot of studies that have looked into reversibility of diffusion restriction and ADC. And I'm sure as fellows, you would have also come across this. So you would have seen a lot of cases where you have seen your ADCs and diffusion restrictions, and we say, wow, it's a big infarct. And then after some time, you see those images, they have regressed quite a bit. And we are actually surprised. So what we understood is the MRI, ADC, and diffusion restriction is not the sine qua non, or it is not the authority to say that this is the amount of infarcted tissue that we can see. You're getting it. So people still, as long as we don't have a very good image to, or a very good type of image to record how much is the infarcted tissue, we are still okay to open these vessels. And this is what we are called the outlier theory. You know, if you have done an MT and this patient has done well, one of the first thing that comes to me is because, wow, you got a case where you had a left M1 or left IC occlusion. Let us start there. It's a left IC occlusion. But this guy was so extremely lucky, but because the ACOM was patent and his left AC is preserved. That is his biggest plus. So which means some amount of collateral cell coming. And moreover than that, he's lucky because the subcortical areas are still not infarcted. Well, probably a recurrent artery of Sebnar's, or probably there are perforators coming from the A1 segment on the the left side from the cross flow, and so relatively your left subcortical areas is still preserved and fighting for a chance. In these cases, if I have to be a devil's advocate, I would say you could still go for an MT, considering that the cortical areas are more involved than the subcortical areas. This would be my argument. But guidelines, no, we are not there yet. But if you were given an option to go outside the guidelines, look at it from compassionate grounds kind of thing. Meaning this is an elderly guy. Meaning not an elderly guy. This is a guy who's on a dominant hemisphere and he has quite a lot to lose. Maybe if we are really aggressive, we do a mechanical thrombectomy and look at decompression as a possibility, then I would argue in favor of him. Let us try this and then possibly look at possibly look at an early decompression. In these images, there is another reason why I would like a CT, which I will explain at the end of the session today. Why CT would also help in this case. Please go ahead.
Sure. 1 second. So yes, sir. As you suggested, we took this patient for a thrombectomy. Then this was his first shoot initially, which we took from the common carotid injection. This is the first shoot. So as you can see, right now you can see maybe it's feeling like a distal ICA occlusion, and also you can see a tight stenosis in the proximal ICA, and the proximal ICA is slightly dilated. Doesn't look like a pseudoaneurysm, though it is slightly dilated. So this was the first shoot which we took, and this is from the lateral view. As we can see again clearly that the proximal ICA is slightly stenosed, but still there is filling across the stenotic segment. And here we are not able to make out exactly. Maybe you can see this might be the ACA and the M1 might be occluded, or might be slightly a distal ICA occlusion. So, and Dr. Justin, if you can volunteer, how would you go forward with this, and then we can take inputs from Dr. Kaushik.
First of all, we try to pass a microwire through the stenosed area. Then try to blast it. With a balloon and go for distal approach.
Sir, I'll just tell you. I'll just take few steps forward. Then we can come from the.
Yeah. Please go.
So what we tried was, we initially tried to advance the guide across, but the ballast was not advancing. Then next we tried to advance the react. Even that was also not advancing. So as Dr. Justin suggested, we took a microwire across the stenotic segment. We took a balloon. This was an AccuForce 2.5 into 10. And we did a plasty of the stenotic segment. and then we took a repeat shoot, which now you can see clearly that the M1 segment is occluded, and then we took the guide and the react up above that. So any other which way that we can do this, sir?
Yeah. Can I see this big view again if it's possible for you?
Yes, sir. Yes, sir. Sure. Yes. Sir.
Okay. This is very interesting, because
Yes,
what I would have expected was a distal IC occlusion. And usually when you have a distal IC occlusion,
yes,
the entire ICA, possibly just beyond the bifurcation, becomes invisible.
yes, sir.
Yeah, I'm sure you would have seen these terminal IC
Correct.
occlusions where you won't see. Now, this
Yes,
is a big problem as an interventionist. Why?
Yes.
Because you do not know how much is the clot extending and what materials to use.
Yes, sir.
Correct. Now,
Yes.
also there is a major point in your hand. And what is the major point? The major point is that you have to choose your device.
Okay.
Either you have to choose a device that is a stent retriever, or you have to choose a device that is an aspiration catheter.
Okay. Okay.
So now think about this. Supposing you have a stent retriever, then you know that when you're going into this artery, you do not know the exact location of the thrombus or how deeply it is extending. So stent retriever is no longer a business. So you're probably looking at an aspiration catheter system only to go in. Correct?
Okay. Yes, sir.
Okay. Now what happens is, in this case, you are able to see a distal thrombus, and to some extent you are able to see your internal carotid artery is relatively straight.
Yes,
Which
sir.
means once you are into your carotid bulb and just beyond that, then it is good because relatively it's a straight artery.
Yes, sir.
Problem comes, Dr. Fazal, when you don't know how this artery is going to be.
Yes, sir.
So, for example, you have a left IC occlusion, and from just after the carotid bulb itself, you're not able to visualize the artery, which means you do not know the loops, you do not know how many turns it is taking, and all that.
Yes,
So, if
sir.
that was the case, I would have taken a right IC shoot just before going into the left IC, just to
sir.
understand the anatomy, because it's just a mirror image,
Yes, sir. Yes, sir.
Okay. So, in this case, since it is a straight artery, I know that my aspiration catheter is what is required to do the job.
Yes, sir.
Now, for my aspiration catheter to go inside this, I need stability in the system. It's like building blocks.
Yes, sir.
So if you want to build your blocks, that means your base should be very strong.
Okay.
Which means your ballast or your neuron max or your base or any other catheter, supporting catheter that you want to take, at least has to cross that bulb, if required, even cross that stenotic segment.
Yes, sir.
And remember, you are now dealing with a patient who has come with you after 10 to 12 hours after stroke, which means the clot is going to be really hard to aspirate.
Yes.
So you might have to do this multiple times.
Yes, sir.
So there is no point in keeping your, your sheath or your guiding catheter, whatever, down in the common carotid.
Okay, sir.
So you dissect this left IC, it gets reoccluded later. It doesn't matter.
Yes, sir.
Because you had seen in your MRI that the cross flow across ACA is good.
Yes, sir.
So all you want to do is open up the left M1.
Yes, sir.
The patient is probably symptomatic because of the left M1, because the left IC, assuming this is the tight stenosis the patient has had, the patient has probably survived with it for a very long time.
Yes, sir.
So your idea at that moment is only about the left M1.
Yes, sir.
So go all out. You take a ballast, you see this, immediately you take a run through or a BMW, because that is probably your cheapest wire available in the cath lab.
Yes,
even if it is an ox balloon, go in. I would probably use a 3.5 or a 3.75 balloon, whatever be the case. Dilate even before the artery collapses. I will take my catheter up.
Okay, sir.
If required, sometimes just put that balloon over into the IC, inflate the balloon, give that support, and push my ballast catheter up.
Okay, sir. Okay.
In this step, what I would suggest is that don't waste too much time to remove your balloon and your microwire, insert a thermo, and then go up. Because you have seen this when we are doing carotid stenting. Sometimes these carotids just collapse, even after plastic collapse. So you have taken some effort to open up this vessel.
Yes, sir.
So immediately you go in, you open it up, and you just go distally. Can you show me the next slide?
Yes.
Yeah. So this is the same thing. I think there is a distal IC occlusion. I'm not sure. It's not very clearly visible here. But can you go to the next slide? That was most interesting here. Yeah. Yeah. This was even before you aspirated, is it?
Yes, sir. Yes, sir.
Now, do you remember your TOF images?
Yes, sir.
And do you see this image? What is the
Yes, sir.
huge difference here, doctor?
There we could not see from the opposite side through ACOM, we did not see the MCA filling up, sir. We could only see that the bilateral ACAs were filling up from the opposite side.
Can you
And
go
the
back to that
ICA was
slide?
completely not visualized.
Exactly, exactly. Can you go back to that slide? It's very interesting now. See how the story is developing.
Yes. Yes.
See this? You are not
Yes.
able to see your left IC at all.
Yes.
But here, even before you didn't do anything and you are able to see your left IC. You didn't
Yes.
even aspirate. You didn't put a mechanical thrombectomy. You only loaded them with antiplatelets. So one theory is your loading of antiplatelets itself opened up the vessel. What
Yes.
could be the other theory, Dr. Fazal?
Sir, other might be because the MCA is occluded, it's looking like a pseudo occlusion, that the vessel might be collapsed and we are not able to visualize the ICA.
Why are we not able to visualize? It's an MCA, na? Go to the slide where you are seeing the MCA. Yeah. So you are seeing the carotid so well, na?
Yes,
Your
sir.
MCA is so distal.
Yes,
So why
sir.
are you not able to see the flow across the ICA? Because what you're possibly dealing is with a critical stenosis in the left IC down,
Yes,
so the
sir.
MRI had overestimated it and it's not visualizing your left IC at all.
Okay, sir.
Now, why am I talking about this? Can you see your left MCA, the left M1 occlusion that we were talking about? You are
Yes.
seeing that the left M1 is more distally occluded than proximally, correct?
Yes, sir. Correct. Correct.
Which means your perforators are still preserved.
Yes, sir. Yes.
And that explains why your subcortical areas are still not showing the diffusion restriction which you saw before.
Yes, sir. Yes.
You're getting what I'm saying?
Yes, sir. Yes, sir.
And another such a fantastic point now is that if you do a mechanical thrombectomy to this patient, because you have a left IC stenosis that is proximal,
Yes.
reperfusion injury is going to be lesser in this patient.
Yes, sir.
So I will not stent this, but this is for practical reasons. It's a left M1 occlusion. It's a tandem lesion.
Okay, sir.
The left IC was tightly stenosed, and
Okay,
then
sir.
from there possibly there is a thrombus that has gone and occluded the left M1.
Okay. Okay, sir.
If there is a left M1 occlusion, it's a distal M1 occlusion rather than a proximal because my subcortical regions are spared.
Okay, sir.
And the patient is surviving this so long because your left carotid artery was stenosed for such a long time that his collaterals are developed so well across the ACA.
Okay, sir.
Like you are having so many good things to talk about this case now that this is the right, it's a good case to do a mechanical thrombectomy. It's no longer about your diffusion and aspects. So you
Yes,
start
sir.
thinking, oh wow, see, left IC has been stenosed for such a long time, which means the collaterals are good. That means
Yes,
your ischemic penumbra is going to be bigger, your score volume should be low. And the
Yes.
symptomatic part, even if he had a left M1 occlusion, it's a distal M1 occlusion rather than a proximal, which means your subcortical and your perforator areas are preserved. And that is very clear in the MRI.
Yes.
So now what you're going to salvage is possibly the clot progressing proximally and the subcortical areas that you want to preserve rather
Yes.
than the cortical areas.
Yes.
It's a fantastic case to have, Fazal, because after
Yes.
you open up this vessel also,
Yes.
this is not going to go in for a reperfusion.
Yes, sir. Yes, sir.
So I am very excited to see what has happened to this case. Please go ahead.
So, yes, sir. Then we did a thrombectomy, sir. We passed the ballast across and placed it in the petrous segment and then took the react. And with embotrap, we did a mechanical thrombectomy using Solumbra technique. And this was the embotrap stent retriever which is placed and using the Phenom 27 microcatheter. So this is this thing. So we were lucky and with a single pass the vessel recanalized, sir. So this is the shoot after the first pass.
Very nice.
So we could achieve a TK3 recanalization, and now the vessel is recanalized. Sir, now the $1 million question is: patient has already received a loading dose outside, and whether now you need to stent this or not, whether to stent the proximal carotid or not. As you saw, it was a very, very, very tight stenosis in the proximal ICA, whether to stent it or not. Dr. Justin, if at all you can volunteer, then we can take input from Kaushik sir.
Sure. Would love to hear what are the things.
Yeah, this patient is already loaded with antiplatelets and have critical significant stenosis, symptomatic stenosis.
Okay.
So we can go for stenting in the acute setting also.
Okay. Thank you for your input. And sir, I'll tell you what we did, sir. If at all you can, how would you approach and what would you do, sir?
See, Dr. Fazal, my major concern in this patient is two things.
Yes, sir.
The first thing is that we are now opening a vessel which is probably 12 hours, 13 hours into the window, and we have already used a React, we have used an embotrap, we have used Phenom. The cost is also adding up.
Yes, sir.
And I'm very, very worried about reperfusion injury in this patient.
Okay, sir.
But what I've seen that he is having a left IC critical stenosis that was there down.
Yes, sir.
And I know that he has been living with this disease of a carotid artery disease for quite some time.
Yes, sir.
The reason why he has come to our hospital is the left M1 disease.
Yes, sir.
So I will open up the M1.
Okay.
I will wait and see whether this patient turns a carotid artery stenting.
Okay.
If this patient improves over time, we have given enough antiplatelets.
Yes,
we have opened up the vessel now. We do not know what is the kind of reperfusion injury he is going to have.
Okay.
So in these cases, as long as your cross flow was good, as demonstrated by the right, your shoots, which is showing a good ACA coming in and the ACOM is good and your MCA, it's filling all the way up. These are cases from which we will probably not stent the carotid.
Okay.
You have done a good plasty, you remove your catheter, and I would leave it there. Because if I stent this carotid and then I add an expense to the patient and I add the risk of reperfusion injury that is now going to go higher, because obviously we don't have enough data to say which are the case, whether it was an ideal case to do MT in the first place.
Okay.
I know that this patient has been surviving with this left carotid artery stenosis for quite some time.
Okay.
So this would not be an ideal scenario for me to stent.
Okay.
I would wait. And more importantly, let us say that this patient requires a decompressive craniotomy.
Okay, sir.
You're looking at that. You're looking at a possibility that we are going to be aggressive with this guy. So now, if you have stented this patient, you are also looking at whether to start, reverse the antiplatelet. How long should we give? 48 hours we are not going to give, and that would mean stent thrombosis and stent related issues.
Yes.
So every step that I'm going to take from here, I would not like a stent in my carotid. So I know he has been living with it. He has come to me with a left M1 occlusion. Obviously, the carotid has only thrown it. I will go and I'll remove it off, but that's it. After that, if he wants a carotid stenting, he has to on it again.
Sure, sir. Sure. So there, after a brief discussion in the cath lab, we stented the patient. We used a 8640 exact carotid stent. And we did not post dilate this patient. We did not do a post stenting dilatation. We just put a stent and we just came out. So this is post the stenting. So this was his scan on 8. Patient, even though this is the infect that we can see on the CT, currently still the patient is in the ICU, but his power when he came was 0 in both right upper and lower limb. Now his power in right upper limb is 2 and in the right lower limb it is 4. And from global patient has come to motor aphasia where he is verbalizing and even trying to communicate. This is the current status of the patient. So as maybe before we proceed, any comments, sir, on this case before we proceed to the second case?
Oh, you look at the CT, na? Your subcortical areas are nicely preserved here.
Yes, sir.
Compared to the cortex.
Yes,
so this tells you that this is a left M1 distal occlusion. And the carotid was how do I say? I think the MR just overestimated the carotid.
Yes.
It showed you that it is the left IC that was completely occluded and all that. So this is a fantastic scenario to have. Now you are thinking of a distal IC tandem occlusion and go in, and then you see a tight stenosis proximally, and distally an M1 that is, very distally there is occlusion with the perforators being preserved. I think it's a very good case. And also because there was a critical stenosis in the proximal segment of the carotid, I
Yes.
think the collaterals had developed so well for this patient even to start with, from the ACA and everywhere.
Yes.
And so it kind of primed the brain for a major stroke. And that is one reason I think this patient survived, you know, with this. And another thing is, it was good to use the embo trap, because you were probably going more distal when you saw the left M1. That's a fantastic idea. So we were talking about this. We are also now looking at clot composition based on CT images. And we are trying to publish the study across. Hopefully this month or so it comes. So we look at the CT images, and usually your hyperdense clots are associated with RBC clots, correct?
Yes.
And these RBC clots permeability, if you see, their permeability is good and they're very friable. In those cases, you know, a simple aspiration would work. But if you don't have a hyperdense sign, meaning it's not universal, but this is what we are trying to push across, then the permeability of the clot is very low, meaning you don't see the hyperdense sign. The permeability clot is very low because it's a fibrin-rich clot, and they are very difficult to treat with simple empty techniques. And in those cases, possibly React plus Embotrap would be helpful. So your Solumbra technique was good. Maybe, just maybe, after I had seen that left M1, I would not have been very confident taking a aspiration catheter up. So I would have just gone in and taken a Embotrap first itself, and then taken it back. And most likely my left carotid, I would not have required a balloon guided catheter, because there was a proximal stenosis also. So I would have probably reduced the cost with just one stent retriever. But no harm done. I think Solumbra was a very good technique because you got a first pass recanalization. But I think the clue to this patient was the diffusion restriction that you saw first. Why the cortical was involved and the subcortical was not involved in a patient who has a left IC occlusion. That was amazing. So I think the MRI just overestimated this. And once your angio was done, it was very clear. I think it's a fantastic case, doctor. Your team was very brave to open this case up. I think it's really good. I think this patient will make a very good recovery. And this is on 8th, the CT. It's still not showing good amount of any edema and all that. And again, I am telling you, this brain has been nicely primed because of the critical stenosis there down. So the collaterals would have been fantastic. And I wish you could have shown some images of the collaterals, and I'm sure it would have been good. And that is what is looking very, very area.
Sure, sir. And as a fellow, maybe one take-home message from this is, and Gigi sir also keeps on emphasizing it again and again, saying, I mean, like, we shouldn't be too strict regarding the guidelines because the treatment is still very much evolving. And this might have ended up in a completely different way. As you were suggesting, same case, maybe we might have come out of the cath lab and next CT would have shown a big, huge hemorrhage. So we really, it's really difficult to predict who's exactly going to benefit as this patient. So we cannot deny certain patients treatment, sticking very, very strictly to the guidelines. So
not necessarily, Dr. Fazal. I think here what we need to understand is completely different. See, before 2015, all trials failed. Correct. And we were exactly like what we are probably turning around now. We are becoming more and more confident that I can open up every vessel and we can possibly get a good result. It's not that. I feel we missed out a trick then. We missed out a trick in between. We are still missing out this trick. And what is this trick is that the outlier theory. What is the outlier theory? Let us say this patient had come with a CT scan first, not with an MRI, or you had done a repeat CT over here, your aspects would not have been bad in this case.
Yes, sir.
Do you agree or you disagree?
Yes, sir. Yes, correct.
So your aspects which you talked in your MRI was an overestimate. It was 4. Probably this was a case who would have done an aspects of around 6 to 7.
Yes.
So it was still not a very bad case for you to take.
Yes.
The second thing is to understand the other theories as to why this patient survived.
Yes.
Now, retrospectively, we can sit in a discussion like this and talk about why. See, there's a stenosis here. There's a top image that has mismatched. There is a left MCA that was distally occluded and all that.
Yes.
But what is most important is how do we do this exercise quickly? how do we do this exercise fast so that we pick up this outlier theory? Meaning, there are some patients who do extremely well despite the time last seen is different, despite the fact that your collateral assessment is bad, and suddenly these patients do extremely well, and we are
Yes,
still
sir.
not able to answer those.
Yes.
So I don't think we should say, as long as this subject is evolving, let us open up these vessels.
Yes.
Either we should do two of these things. Either we, go back and analyze those patients who did really good, or look into those cases which why they did well after your beyond your dawn or diffuse criteria.
Okay.
They are called the outlier theory. We have to go back and see why did these patients do well in the first place.
Yeah.
Like, for example, this is a good case.
Yes.
You might not have thought that this patient would have done so well, meaning none
Yes.
of us would have thought after a left IC occlusion in that. But
Yes.
I'm guessing, when you're showing me this case, I'm trying to find out why this happened. And
Yes.
these theories, once you start putting them into data, suddenly you will analyze a pattern of patients who will actually do well in these scenarios.
Sure.
So I think we'll be very brash if we say, no need to follow the guidelines and let's just open up the vessels.
Okay.
Because that is what failed those 2015 and pre-trials.
Okay. Sure.
Okay. So from 2000 diffuse and all that, and then we can start doing it.
Sure, sir. Sure. So we'll proceed to the second case. So before proceeding,
actually one doubt is there.
Yeah.
Doubt is there in the chat box.
Yeah.
Yes, sir. Please.
Asking for the reason for not to do balloon stent plasty in this patient.
I mean, that is post stenting or?
Actually, only this much is being written.
I think they would be suggesting, I think, why was a dilatation not done? I think post stenting, I guess.
Yeah, post stent they have mentioned. Yeah. Dr. Chandra has mentioned post stenting.
Okay, I have not actually put multiple images that we did post stenting from the ballast from the guide. Actually, it doesn't look too tight as it is being seen in the below images. We thought it was adequately open, and this was just 2 to 3 minutes later. The 5 to 10 minutes later, we had waited and taken again shoots. We showed it to be considerably open, as it is not looking as tight in the subsequent images.
If I also feel that not dilating the stent after that would prevent a reperfusion injury. That is one more thing that I would have thought. But obviously, you had done the case, so you had your own reasons, I guess.
Yes, sir. Yes, sir.
I think there is some more questions here.
So one more doubt is that if at all we are planning to do stenting, what about the size? Like in this picture, we are seeing a apparently oversized stent to the compared to the collapsed vessel distally, probably due to chronic stenosis.
I agree. In fact, it's a very nice point that somebody brought out. Meaning, if you go back to those slides of the carotid stenosis, also, that is very intriguing. The bulb and the proximal part is so nice. Just distal to the bulb, you have a critical stenosis. Why should this part be stenosed with your bulb and the proximal part showing so nice? This is a question that I'm not able to answer in this image, because usually when you have an atherosclerotic lesion, you see a very dirty vessel. You have seen this so many times. Whereas in this patient, it looks slightly different. And meaning, I don't know, with whatever images I'm having, it looks slightly different. And yes, oversizing this stent it looks like it's a little oversized in this. If you can show the image where you put the stent, your distal ICA is probably a little smaller than your stent.
Yeah, even we thought after putting the stent that we had slightly oversized it. Yes.
You see this, so it looks like that. But I think what we have to appreciate is when we are trying to do these under odd hours, quickly trying to open these vessels up, I don't think you have the time to measure everything and go. You're probably in a Hail Mary situation. You want to keep the vessel open, and sometimes we do get carried away. I agree. Meaning, I can easily sit here in a box and tell you should have sized it 3 by 8 or something like that. But I think the points that they have raised is valid. And to beat that would be asking ourselves the question, what would we achieve by stenting this vessel? That is the first question that we need to ask. What will we achieve? If we are going to say that we are going to achieve good circulation across MCA, I think that would have been a bummer, because the ACA is anyway supplying that side. So I would have waited for it. Maybe if you had prevented another stroke from happening because you feel it's a critical stenosis and a dirty plaque, then probably stenting with that would matter. So I think we have to understand why we need to stent this. But I think the points are well taken, meaning oversizing a stent and then putting these patients on antiplatelets in a condition where you are desperate to prevent a reperfusion injuries and all that. I think a stent could have been avoided, but that's a very personal choice. Meaning, I know the debate is out. Everybody has their own view about stenting or not stenting.
Okay. If no further questions are there, we can proceed to our second case.
And one more query is like,
Yeah.
is this a variant of web? I mean, probably mentioning the distal stenotic part.
Web. Could be. I don't have enough image. Having said that, the age of the patient, what is the
Age might be some 62 to 63, sir.
age of the patient?
62.
Yeah. Okay. No, it could be a variant of a web, meaning we could probably go back to its original MRI images that were done, but even then the TOF images did not show anything. Very difficult to say whether it could have been a web. But the moment your carotid is so free and there's just a small, not a small, meaning a lesion there just distal to it, and then the IC is looking very thinned out, I will raise my concern as to whether this is really an atherosclerotic disease, and do we have enough data or enough supporting evidence to stent it. So the moment I see this image where your bulb is very free, and then just beyond the bulb you have a stenotic segment, I would think twice before stenting it.
Okay, sir. Okay. Anybody, any further queries? So
I think there was one question on here, some in the chat box. It says, should we go for DSA and assess to do or not to do MT depending upon mismatch? I am not sure what mismatch. In theoretical sense, yes. Meaning even according to guidelines, we'll have to look at mismatch between either diffusion flare or perfusion, in fact, mismatch and all that, diffusion perfusion mismatch. But having said that, with the data that we have, when you have a tandem lesion and that there is a good amount of brain that you can salvage, then I think you should go into it a DSA. But yes, you could probably go a mid path here, where you will take a right-sided shoot well, look at the collaterals also to understand what is happening inside the brain. So that will give you an idea as to, okay, let us look at the corollary. You have a left IC occlusion all the way to the distal IC MCA, and this patient is having only infarcts in the cortical area. So that is very surprising to me. So probably I will do a right-sided IC run, also to look at how the carotids are supposed to look, because for me mentally I'm thinking the IC will not be visualized. So I'll take a right IC shoot. I will see how the collaterals are indirect, meaning supplying the left side, and then I'll come down and probably go into the left.
Right. So we shall go to the second case. So before going to the second case, I would request any fellows, to kindly volunteer and just keep on presenting. Let us take this as a forum to discuss cases, bring out new ideas. May that be it a simple journal or an interesting case that you have come across or anything. You can just feel free to contact Dr. Jaishankar or me, so that we can just discuss here, and also we can take this as a forum to get to know each other. So we'll go to the second case now. Here is a 75-year-old male patient with no known comorbidities, presented with complaints of left-sided weakness and facial deviation since 3rd of June. So he was initially evaluated at a nearby hospital where an MRI was done, and he was conservatively managed with antiplatelets and statins. Then later, after 2 days, patient started worsening and developed neurological deficits in the form of increased weakness. She had a very minimal deficit with the 4 power in the local hospital. So he
Fazal,
had
I'm sorry. Somebody had asked for keeping a full screen.
Yes, sir. So he had the worsening of neurological deficits after 2 days in the form of increased weakness, and patient developed a gaze deviation to right. And later, because of the worsening status, patient was referred to us for further management. So when the patient came to us, patient was conscious, patient was obeying commands. There was a gaze preference to the right, and the left upper and lower limb power was 2. So this was the CT brain and CT brain angio that we took. You can see there is a right dense MCA sign that you can see, and there is a doubtful infarct in the right parietal region. And also this is the CT angio that we took in our hospital. You can see the right proximal M1 is not visualized. And also you can see this is the MRI that we took here. And you can see the infarct in the insula, the external capsule, and there are very minimal flare changes, though there are mild flare changes, but it is not still very clearly evident in the flare. So here there is again acute infarct, where you can see there is a good amount of flare changes in this infarct. But whereas in this near the operculum and in the insula, you don't see much of flare changes. So this is the patient. And now how would we manage this patient? Whether to take this patient for a thrombectomy, whether it's almost 2 days or 3 days since the onset of stroke. So whether to just continue with the conservative management, or as initially somebody was suggesting to do a check angio, maybe to see the collaterals and to decide on table depending upon the vessel to whether to recanalize it or not. So if anybody can volunteer. Dr. Justin, are you still there?
Yes.
Yes, Justin.
Can you show the MRI again?
Yeah.
Okay. This.
I mean, might be a late progressor. Maybe mild deficit he started, and he's slowly started worsening after 2 days.
Yeah. Okay. This MRI is of single time, no? This MRI is same.
This was on the day he presented to the hospital. It was not on the not in the hospital, local hospital. This was when he presented to us.
Okay. That means he has more established stroke. Next William, please.
Yeah.
Yes. Almost involving entire MCA territory. Flare changes are in inferior division this time, and first one is on superior division. And then this means like both of NC are involved. Divisions are involved here. And there is an M1 cutoff, no? Proximal M1.
Yeah.
Yeah, what was NHS for this on arrival?
NHS was around 12.
12 only, okay.
Yeah.
It's very difficult to decide on this patient.
No issues, just if at all. I mean, just imagine you are sitting.
Sitting
now, you're practicing now.
I will go for a DSA.
Okay.
For collaterals and to open up or not, I'm not sure.
Just don't worry. Even I don't know. I'm just moderating, sir. Sir, how to proceed with this case, sir?
Fazal,
yes, sir.
Let's start with the story. You know, I always tell my fellows also this: every stroke is telling you a story.
Yes.
So this is a 75-year-old gentleman.
Yes, sir.
Who had left-sided weakness. Okay, facial deviation. So it is a right MCA territory. infarct, correct?
Yes, yes, yes.
So now the question that comes to me is, this patient became, over 3 to 6, that's 3 days he started to worsen.
Yes, sir.
So my first
I
question
mean,
is
actually,
why?
he started, sorry, sir, sorry for interrupting. Actually, he worsened on 6th, sir. I think there was a status quo between 3rd and 6th. And on 6th, he started worsening.
Correct. So
Yeah.
let it be like that. So the first thing that is telling you is, and this is worsening is how it is on the same cerebral hemisphere. It's not
Yes,
in a
sir.
different cerebral
No,
hemisphere.
sir. No, no.
So your vulnerable area is the right cerebral hemisphere. He had a weakness on the left side and facial, and now it has gone to a gaze deviation.
Correct.
And this has happened over 3 days. It is a stuttering stroke or a stroke in progression, correct?
Yeah. Yes, sir. Correct. Correct.
So now the first question that comes to my mind is, the same territory is getting worsened over the last few days.
Yes, sir.
Correct?
Yes, sir.
So the vascular territory, I would still not put the carotid, because if there's a carotid and an embolic stroke or a hemodynamic stroke, it won't worsen like this.
Okay.
So for me, I would be thinking about a focal lesion, possibly in the right M1. That is how I will start my case, correct? Okay, I'm going to have a focal lesion in the right M1.
Okay.
So this is what has happened. So, okay, this was a patient who had a stroke. Now he is having a bad stroke because the gaze preference has started coming now. That is telling you a proximal lesion.
Yes.
Can you go to the next slide?
Yes.
So your CT eyes are already showing that it is looking to the right. Okay.
Yes,
And
sir.
what it is showing is, it is showing a hyperdense right MCA.
Yes, sir.
And a long segment. Correct?
Yes, sir.
But what it is not showing is, your MRI has shown infarcts in the superior and the inferior division.
Yes, sir.
The superior division was older and the inferior division is probably developing now.
Yes, sir.
But the MCA hyperdense sign that you're seeing right now is actually in the proximal M1.
Yes, sir.
So what is happening is, to my understanding, the clot is progressing more proximally. So you are getting more and more RBC rich clots that is coming from the M1 segment distally and coming towards the proximal segment. And that is why your patient is worsening, which means I am looking at a lesion probably at the M1, M2 junction.
Okay, sir. Okay.
Go to the next slide, please.
Yes, sir.
Now, I am not able to see this carotid well on the right side.
Yes, sir.
Is it not there?
No, sir. No.
Okay. So the right sided carotid is also not there. So you have a patient who is having not only an M1 occlusion, you have a carotid also that is not visualized now. So now my thing is going further. Okay. Now you have a carotid lesion and you have an M1 lesion and possibly an M2 lesion. So I don't know whether there are small thrombi that are coming up. But what you can see is, despite the right MCA that is cut off, you are already seeing branches that are coming in the right MCA territory. Agreed?
Yes. Agreed, sir. Agreed.
So there are some collaterals that you can see, which tells you that there is a long-standing lesion that is going to come your way.
Yeah, okay, sir.
So now I am prepared that either I'm going to have a tandem occlusion.
Yes.
Definitely I'm going to face with a stenosis somewhere, either in the carotid or in the MCA. So the DSA would tell me a good thing, but it also tells me that this patient's brain is a little more resilient to ischemic work, because he has been having these lesions for a long time. The collaterals are good. He has had a stroke recently in the same territory, and your right IC is not visualized. So I will be thinking, okay, this is going to be a resilient area. But having said that, now going in is going to be a challenge. So in this case, when I'm doing the DSA, I would not go with an idea of empty first, but I would do a DSA and start with what is the collateral supplying from the right to left and everything before committing to, or I'll decide, like you rightly said in your slides, to do an empty on table.
Okay, sir. Sure. So this is the DSA picture, sir. This is a right common carotid artery injection. So you are not able to, I mean, completely the ICA is not visualized, but what we can see here is, if it all
the collaterals.
Yeah. Sir, actually left side shoot I have not got it.
I think the right ECA ICA anastomosis is there. Is that right? Meaning I'm seeing a faint.
Correct, sir. Correct. Exactly. That's what I was just about to point out. If at all you can see a trickle of blood in the distal ICA, and I think you can even visualize the ophthalmic artery also.
Fantastic, doctor. Please go ahead.
Yes, sir. So this was the initial shoot. So what would be the next step? If at all now we are deciding that left side shoot I have not got, I just apologize. So whether now if at all we have taken a step that we need to on table now, after consideration we are deciding to do a thrombectomy, then how would we proceed with this case?
Go to the previous slide, Dr. Fazal.
Yes, sir.
You are not able to see the ICA origin, is it, or just a stump you are able to see?
Yes, sir. Slight stump, sir. We are not able to see the ICA, sir, actually.
So you're seeing a small stump there, na?
Yes.
Now,
sir.
this is the tricky case that I was talking to you about in the previous one.
Yes. Sir.
Because you do not know how long your thrombus segment is, how straight your vessel is going to be,
yes.
And more importantly, how much is the thrombus load.
Yes. Sir.
These are all very, very dirty vessels to start with.
Yes.
So we have had this question a long time, and
yes.
we are also understanding that this is a right MCA occlusion also.
Yes.
Of course, if we do the left, we will know whether it is distally going or not, whether there was a cross flow that was established. Did you even do a left ICA shoot?
No, sir. No.
You didn't do. So I would recommend you to do that, because if we want to know whether this was the flow across the your ACOM was good or not to start with.
Yes. Sir.
But anyway, so now what is happening is you have an ICA which is filled with thrombus and
yes.
would be a chronic occlusion, and you have to go inside and you're going blind.
Yes.
So in these kind of scenarios, what we do is we take a thermo up, micro wire and all won't work. Because your micro wires are meant to be wires that are not supposed to perforate, not supposed to injure and not that, but it will not give you the support to go. Again, a left IC shoot will give you an idea of how the right IC was going to look like. Is it a loopy one? Is it going to be? Imagine your thermo starts looping beyond one point. You don't know whether you have perforated and gone, or it is the normal anatomy of the case. Then what happens is, this is a very interesting point which we can use it to our advantage. So the moment your guiding catheter goes into the IC, wherever it goes into the IC, just connect it to your pressure pumps. The biggest advantage of an IC is the IC doesn't have any branches or significant branches up to your ophthalmic segment. Of course, we are talking about maybe the ophthalmic artery or your PCOM or your choroidal. They are all small arteries. But before that, your petrous and the cavernous and all that, it doesn't have significant branches. And we use that to our advantage. Why? Because when we aspirate the clot from here, now it is almost an end-to-end aspiration. It behaves like a single artery. And once you aspirate it, now see, I'll tell you the problem here. When you go back to your MRI, can you go back to your MRI?
Yes, sir.
Yeah. MRI, sorry, not MRI, the CT angio. Next one.
Yes.
See, so you have a faint filling of your distal IC and the right M1. Can you see that?
Yes, sir.
And so you know that some part of your distal IC and the M1 is actually open.
Yes, sir.
Now, if you blindly taking a catheter system up without aspirating the clots below, means you are actually endangering the territory. And you already know, according to your MRI, that your perforator territories are all well spared.
Yes, sir.
So you don't want a clot to go into your right proximal M1 for whatever, sir. God forbid. So basically what you want to do is you want to clean your artery. At the same time, you don't want any clot to go migrate distally. So in these cases, what you will do is the moment you place your guiding sheath or cerebase or whatever you have inside your IC, the moment it beyond the IC, just connect it to your suction pump and allow it to remove all the clot. If required, you can even go for another kind of a guiding catheter, an ox envoy or an ox neuron, to go in and keep aspirating it. It's going to be a very dirty vessel. Keep aspirating it till you see the ophthalmic segment. Just keep going ahead, aspirate. Then possibly you have an access to treat your right M1. In that process, if this artery gets occluded or when you come back you see a stenosis, I would leave it, because I will feel that this is a long-standing lesion with such a huge thrombus load, and I would leave it.
Sir. Right. So initially, as you said, sir, after a couple of aspirations, we could just see a slightly distal part beyond the stump. So what we did was we passed the microwire. We tried to pass the microwire across the lesion, and it somehow went through. So again, we took a balloon and did a plasty of the vessel. And what we did was we took the guide across the balloon. Just when we were taking it across, we deflated the balloon so that the guide went across. So it slowly went across the lesion. So this was the lesion after the guide was passed beyond the lesion. So what steps we did was, initially we did, as sir suggested, we did a couple of aspirations. And after that, beyond the stump, we could see the proximal ICA slightly. So we took a balloon, did a plasty. Then we took the guide above the balloon, just deflating the balloon and passing the guide beyond. And this was the shoot from the guide. So now we can see the properly the proximal M1 lesion. So next step, whether obviously we are going to do a thrombectomy. So just wanted to discuss at this point whether there are few centers who do only adapt, and there are few centers who go for Solumbra, and how do you approach an MT if at all we don't know the status of the clot. It's sometimes very difficult in the imaging to tell whether it's a red or a white thrombus and whether it will come out of this thing. Few people even suggest to do initially with a first do an aspiration, and if at all we are not getting it, go for a Solumbra. So any particular this thing that you follow, or
could you
yes,
magnify the slide?
Yes, sir. Sorry.
So you have gone beyond that. You have taken your guiding up. Go to the next slide.
Yes.
Next slide.
This
Yeah.
one, sir?
Okay. Now this is a right M1 cutoff. You can see again, right?
Yes,
so your AC is seen, agreed, but your right M1 is cut off, and possibly it is just after your M1 origin. Maybe just 2-3 millimeters. It's not too distal also.
Yes.
And your CT has already shown a hyperdense sign. And more importantly, the carotid, except for that one loop that is there, there is not much of any tortuosity that you are expecting. So this would be a bad case for aspiration. Now let us come back to the first question that you asked. Adapt versus Solumbra versus badass technique and all that. None of these techniques have found to be having a first pass recanalization set better than the other.
Okay.
So that is the bottom line. So I think it starts with also what you are most comfortable with in assembling and deassembling, the cost that your institutions have. So we don't have any guidelines that say which technique is better than the other.
Okay.
But in terms of possibly, I am a very aspiration guy because I like to quickly finish my case, and I would have already started aspirating, connected my system to aspiration as I'm going up in this case. So I would probably just look at this carotid. It's just a single loop over there. I just need to cross that. So I would just to go for a simple aspiration rather than a Solumbra. And your because your hyperdense MCA sign was also well seen, I would expect this to be an RBC rich clot. So it would aspirate well. The clot length is also pretty long, if you see in the CT, and so that is also going to be a challenge. If you want to put your stent retriever, then you will have to go into one of your M1, M2 divisions. You cannot just go beyond the clot and deploy it. So it should have to be in your M2 division, because if you see the, you show the CT. Can you show me the CT, please? CT angio or the plain CT. The previous one. See, you see the extent of your thrombus, right?
Yes.
So it is from extending from the proximal portion of M1 to possibly the Sylvian area. So it is almost going into your M2 area.
Yes.
So if you are going to go in, your microwire microcatheter has to go so distally. And so which means you'll have to take your aspiration catheter all the way to proximal M1 and then push this across. So if you're going to just deploy it across M1, it's not going to help. So in this case, I would probably look at aspiration and suck the clot from proximal, because I can see it, rather than going for a Solumbra. And of course, cost, Dr. Fazal, meaning
Yes,
I will
sir.
always look at cost. I'll have to use
Yes.
2 mechanical thrombectomy devices.
Yes,
I would probably think of doing it with a single aspiration. If it fails, then I'll go for a Solambra. But for all practical purposes, I don't think one technique is superior to the other.
Okay. Are you using the pressure pump, sir, or you're like the old thing you're doing, you're using aspiration using the syringes?
Pressure pump. We do have a vacuum. Sorry.
Sorry, sir. Do you feel any difference between using the syringes and the pressure pump on based on your experience? How do you think both fare against each other?
No, I think see when you have a vacuolock syringe, I think it is not designed for this.
Okay.
It is not designed for creating a negative pressure for intracranial vessels. But what your aspiration pump does is it is designed for this. And now the newer jet pump that is there, it has only a single connection. I don't know how many of you have seen that the older jet pumps had 2 connections, and our technicians used to always be a little confused as to which goes where. So the newer ones is just connect it and forget it. And it has a nice filter which is picking up the clots as well. So I have a feeling that a pump is very good. Especially in this case, I would have preferred a pump because I would have thought that the ICA load of a thrombus would have been very high. Every time to go in and then your syringe will have very limited amount of barrel space to hold the clots. So how much can you keep aspirating? So I would connect it to a pump and just keep going forward, so that whatever clot just keeps coming out. So in this case specifically, I would have loved to have a pump.
Okay. Is it the same newer generation penumbra system, or is it a different one?
The newer generation penumbra system, because the older penumbra system had I think if I'm not mistaken, 2 connectors. One connector is to the aspiration catheter, and then one more connection is from the pump to the engine. So what happens is it creates the negative suction and does. So you do not know which is where, and it doesn't work. But the newer system has just one connection, just that one that connects to the aspiration catheter. You connect it and forget it. Second thing is that aspiration jet pump has a filter mechanism also. So it collects longer time, the clot gets dissolved or we are not able to retrieve it. But this is easier with this pump now. So I think this newer generation pump is better.
You're saying, I mean, because I've not used the pump anytime, sir. I mean, we have to place it at the face of the clot and just switch on the pump and advance the aspiration, or generally how does it work, sir? Because I mean, what we generally do with syringes is just when you are removing the complete this thing, or you put the catheter at the face of the clot and you try removing it at each and every pass. So how does it work with the pressure pump, sir?
Oh, you have not used a penumbra
No, sir. No, sir. No, sir.
Pump before, jet engine pumps?
No, sir.
Okay, just give me a second. Okay. Okay. I'm just sharing my screen now.
Yeah, I'll just unshare, sir. Just a second.
The host has disabled participant screen sharing.
Jay?
Sir, now I have made you co-host, sir.
Yeah. Okay.
You can share now.
So this is the pump. Can you see this pump?
Yes, sir. Yes.
Okay. So this is the pump. It's a very simple device. You just have to connect a single system all the way to your aspiration pump, and then that. And this white kind of a floor inside this plastic jar. Can you see the
Yes,
transparent jar that acts like a filter? And this is just a button. You press the button, and then this will suck the entire clot, and whatever residual clots will get involved here, and the blood will be here.
Okay.
And it's a fantastic device, meaning especially if your thrombus load is going to be large, this is the device I would recommend rather than every time.
Okay, it's
So
just like you place the catheter near your target area and you just switch it on.
Just like, sorry?
I mean, you just place the catheter near your clot, the face of the clot, and you just switch it on.
Yes. Sometimes I'm a little too, yeah. Sometimes I'm a little too, I wanted to get that first pass recanalization, right? So
Yeah.
sometimes I go a little more into the artery as well. So,
Okay.
I'm not worried about distal fragmentation at times, especially if I feel that, the clot length is long and I'm not able to pull an immediate little fragment. Then once I start aspirating at the tip of the clot, I try to go and suck some more.
Okay.
So that is one, it's a bad technique, meaning I cannot stop
You
myself
mean
because I want.
by advancing the catheter further, slowly when
Yes,
it
with
is
the suction
aspirating,
on.
you just slowly advance the
Yes,
catheter forward.
catheter a little more and then pull it back.
Okay.
People talk about kissing the clot,
Okay.
which I sometimes I feel that it that first pass recanalization effect doesn't happen. For me, even if the clot fragments and goes distally, it is okay. I'm not looking at a 100% result. Even if small fragments go somewhere distally, it is fine, because these are long clots, Dr. Fazal. When you're seeing these clots at the size, there is a very good chance that it can fragment. And so, meaning people show that, I have demonstrated pulling a very
Okay, sir.
long clot, but most of the time you end up not pulling it and fragmenting it. So when you have vessel first, that is mine. But yes, most of the times I try to kiss the clot and then suction it up.
Okay, sir. Okay. So just yeah. So coming back to this case, then yeah. Again, we did a Solumbra technique, and we could recanalize the vessel. This was the shoot after the Solumbra. Now, again, as you can see, there is after the recanalization of the MCA, you can again see a stenosis in the proximal carotid. So again, we have had this discussion. As usual, would you stent the carotid, and if yes, now or later? In this particular case, we decided not to stent the case. So this was just left alone, sir. We did a carotid stenting actually at a later date. This was the CT of the same patient at discharge. And patient was discharged after 10 days and patient's MRS was 1 after 1 month.
Dr. Fazal, can you go back to your CT angio?
Yes, sir. The initial first CT angio, sir.
Yeah. So a good point that was you mentioned was the patient was stable between these 2-3 days. So it was not a stuttering.
Yes, sir.
Stroke. It was recurring strokes, correct?
Yes. I mean, sir, that's what, sir. Patient initially developed the symptoms, but as I suggested,
you did try to warn me by telling that the patient did not worsen stepwise.
Yes, sir.
I should have taken that hint before. So it was not an M1 stenosis, it was a carotid artery stenosis which was throwing thrombus, correct?
Yes, sir. Yes, sir. Correct.
So now is a very interesting question, Dr. Fazal. We did this angio at the end, right?
Yes.
You could not see the AC at all from the right side.
Yes, sir.
But your left IC was possibly occluded when you were going your angio in, correct?
Yes, sir.
So you did not have an ACOM that was supplying, and your right IC was occluded when you went in for a DSA.
Yes, sir.
So much so that the ECA ICA anastomosis was seen.
Yes, sir.
Where did this right distal IC come?
Distal, I mean the right distal IC, sir, you mean in the first shoot?
In the CT angio. CT angio. The DSA,
Yes,
The
sir.
right IC was occluded?
Yes, yes, sir.
Only an EIC anastomosis that was faint was seen, it wasn't too much.
Yes, sir.
And patient was otherwise being survived for all the reasons.
Yes, sir.
And the ACOM was not patent because your last right IC shoot did not show a contralateral filling or the ACA filling at all.
Yes, sir.
So how was this distal ICA filling?
There was, as we suggested, there was a ECIC anastomosis, no, sir, that was filling the most probably the ophthalmic segment here, as we can see.
Or it is possibly the PCOM PCA that is filling up. Can you see that slide, that CT angio?
Yes, sir.
See those, the prominent PCOM PCAs are probably coming up and filling up the distal IC on the right side.
Okay, sir.
This is also giving you a clue because when you are seeing these angios, now when you want to assess these cases, you need
Yes,
to
sir.
understand which are the vessels that you want to go in and look into.
Okay, sir.
Because see your, can you come back to the IC run on your carotid? No, next.
Yes.
After your
Yes.
thrombectomy is done. See, thrombectomy.
Sorry, sir, could not hear you. Can you repeat that again, sir?
See, this IC is a very clean IC.
Yes,
Focal
sir.
segmental disease down,
Yeah, correct.
just as the carotid and all that.
Yes, sir.
So I was just thinking when looking at these angios, will we be able to predict what extent the clot is when you're going in?
Yes, sir.
Because your IC was not visualized when you started your DSA, correct?
Yes, sir. Yes.
Probably we should also look into clues in your CT angiogram as to see where exactly your clots are and how you are going to go about it.
Okay, sir.
So this is an IC that is possibly distally looks okay because your PCOM is filling up your right IC well.
Yes, sir.
I'm just thinking aloud. But anyways, I think not stenting this carotid is a good option in this case.
Yes, sir. We just stented it at a later date, sir. With on the same sitting, we did not do just unlike the other case where we stented it. With this, we just decided to leave it alone in this instance particularly.
Okay.
So anybody, if at all you have any queries, can just.
I'm sorry, I didn't get the last part. Can you repeat?
Sorry, sir.
No, I couldn't hear the last part. Maybe my
No, sir. Just unlike the other case, we just decided to leave this patient alone. We did not stent it, but we stented it at a later date. If at all anybody has any queries, they can unmute their mic and just ask their queries, or you can just leave your queries in the chat box. Anybody? Jay, I think we have lost connection also with Dr. Kaushik.
No, I'm here.
You're there, sir. Okay.
Just wait.
Yeah, right. Sorry, sir. Sorry. So, okay, if at all, it's almost 9:30 now. It was a very, very good discussion. I thank Dr. Kaushik Sundar to accepting our invitation and taking part in this discussion. Thank you very much, sir, for taking out.
No, it was nice learning for us also. It was good to discuss. Thank you so much, Dr. Fazal. Lovely cases and good that your patients are all doing well. Thank you so much for the invite.
Thank you, sir. Thank you. Have a good night. And as usual, we'll meet next week again with a few more interesting cases. Thank you so much. Good night.
Good night. Done. Thank you so much. Good night.
Thank you, sir.